Good. So I think most people are in. So welcome to this session on FAIR data. I'm delighted that we've got three speakers who are each going to speak for around about 10 minutes each, and then we're going to have some discussions at the end. So anyone that wants to put questions in, you can use the Q&A function, and I can see those, and we'll pass those on to the speakers at the end. So we have three speakers: Jonathan Stern from Bristol, Richard Fry from Swansea, and Ben Goldacre from Oxford. They're going to introduce themselves in more detail when they speak. But I thought it may be handy for me just to give a very brief introduction to the kinds of things and the kinds of issues that we may be talking about. So if you can just show my one slide, please, Alex. Good, thank you very much. So the intention of this session is really to just talk about how we make data used safely, and particularly though around FAIR. So how do we make data more findable, accessible, interoperable, and reusable? And I have to say this has been a major focus of many groups recently, but most of the focus to date has been around the first part, the F and the A, which to some extent the easy parts, or certainly the easier parts to do. And it'd be really interesting to hear from the speakers around particularly the I and the R. So how do you make the data more interoperable and reusable? And there are different approaches to that the different speakers will talk about. The other kind of element that again, I'd quite like people to touch on is that the FAIR principles are predominantly around data sets. And as we're moving towards things like federated analysis, is there an argument for actually making the code and the analytics approach that you use also FAIR? So how do you make code more findable, accessible, interoperable, and reusable? And I think that will come into some of the talks as well. So that's just to give a little bit of the context, and we can come back to some of these particular areas. If there are other particular issues that anyone wants me to raise with the speakers, stick that in the Q&A and I'll bring that at the end. But for now, I'd like to pass over now to Jonathan Stern, who's Professor of Epidemiology in Bristol, who is going to share his slides. So over to you, Jonathan. Thank you very much.
Thanks very much, Neil. Hopefully you can see that. I'm going to talk about fair use of data at scale, and particularly whole population pandemic response research that we've been conducting using the NHS Digital Trusted Research Environment for England. I'm speaking on behalf of a very large group of people, some of whom I will, but by no means all, I'll mention through the talk. And it's collaborative work, in particular through the institutions listed at the bottom, and funded via the Longitudinal Health and Wellbeing National Core Study. The analyses I'm talking about are based on the NHS Digital Trusted Research Environment that was established through the CVD COVID UK initiative to look at relationships between COVID and cardiovascular disease. We published a description of the trusted research environment, linking COVID lab testing data, intensive care data, NHS digital records, both primary and secondary care, and death registry data, and cardiovascular data within a trusted research environment. And importantly, analyses, the way that these trusted research environments work is that researchers conduct analyses once they've been approved to get secure access, but nothing can be exported from the environment without being independently checked by output checkers who confirm that no disclosive data are being exported. So Spiros Danaxis and his colleagues at UCL have been using these linkages to define phenotypes of COVID infection and severity. And you can draw overlaps and lack of overlap between COVID diagnoses in primary care through laboratory tests, COVID deaths, and COVID identified in secondary care. And for example, by looking at these overlaps, that you can see that of around about 4 million positive tests for SARS-CoV-2, about half of those patients have a primary care record of COVID and half of them don't. So based on all these different ways of identifying COVID, we can then identify phenotypes, non-hospitalized COVID primarily in the second wave because testing wasn't widely available in the first wave, hospitalizations, most in the first wave, hospitalization and intensive care admission, obviously with smaller numbers if you look at the vertical axis, and patterns of COVID death without and with a diagnosis over the calendar time through the pandemic. Now, the CVD COVID UK consortium was established in the spring of 2020 in response to the pandemic, led by Kathy Sudlow. And way back last summer, we established protocols for analyses with objectives to look at the effects of cardiovascular diseases, their risk factors and medications on susceptibility to and outcomes from COVID-19 disease, and the impact of COVID-19 on acute cardiovascular complications. It took a long time as the trusted research environment was established and developed for us to get to the point of having answers to these questions. So I'll start with the first of these, and these are results, analyses led by Venetia Walker from the University of Bristol, investigating the effects of angiotensin converting enzyme inhibitors, ACE inhibitors, and angiotensin receptor blockers, ARBs, on COVID-19 outcomes. A large group of us wrote the protocol middle of last year, and these are the individuals who've been most closely involved in the analysis. And in the trusted research environment, we have data on 5.5 million people, individuals on antihypertensive medications, of whom 3.7 million were exposed to ACE inhibitors or ARBs, doing conventional statistical analyses, either through logistic regression or propensity scores, it doesn't really matter. We see in the odds ratios, the odds of infection and hospitalization, and particularly death, are reduced in people on ACE inhibitors or ARBs compared with people on other types of antihypertensive medication after controlling for a large range of confounding factors. But of course, health records may not include all the confounding factors. So we've also been conducting instrumental variable analyses where, rather than relying on measuring and controlling for patient characteristics, we say that we can identify the overall practice preferences for these types of antihypertensive medication, and use those preferences as what are called instrumental variables to control the confounding. And when we do that, and these results are actually expressed as risk differences rather than odds ratios, we see similar patterns of reductions in infections and hospitalizations and deaths in people treated with those particular types of antihypertensive medication compared with people treated with other types of antihypertensive medication. So strengthening the evidence that these are real effects of the medications and they are potentially protecting against COVID-19 and the worst of the COVID-19 outcomes rather than confounding. Now, we also we spent a lot of time working on the impact of SARS-CoV-2 infection on acute cardiovascular complications. But as you all know, in March this year, we became aware of the likelihood that the Oxford AstraZeneca vaccine led to very rare but serious complications. And so we adapted those analyses to look at cardiovascular outcomes after COVID-19 vaccination. Again, analyses have been conducted in the NHS Digital TRE, using and led by Will. It's a team led by Will Whiteley and mainly involving, but not exclusively involving, the individuals listed here. We published the protocol during April, and the analyses have been done using Cox models with follow-up from 8th of December 2020, the start of vaccination program, to mid-March, when the European Medicines Agency issued its expression of concern. After that time, we're worried that diagnoses may be related to the receipt of particular vaccines. And here are the results, firstly, for any venous thrombosis, where we actually see reductions, particularly in the over 70s, and in the people aged younger than 70, we see somewhat greater reductions for people on Pfizer than people on AstraZeneca. So red, Pfizer is BNT162b2, blue, Oxford AstraZeneca labeled as ChAdOx1S in all the slides. And similar for arterial thrombosis, it's the same basic finding in the under 70s, no strong associations close to the null. In the over 70s, reductions in people who are vaccinated compared with people who are unvaccinated, both 1 to 28 days after vaccination and more than 28 days after vaccination. The primary event of interest is intracranial venous thrombosis, for which we do see an elevation in the rate in people following vaccination with Oxford AstraZeneca, 1 to 28 days after vaccination, with a hazard ratio of around 2. But I'd also, no elevation for Pfizer, but there were only 223 events in the 46 million people followed for a period of 3 months. These events are incredibly rare, and only 39 events in the older individuals and no suggestion of an increase. And finally, for pulmonary embolism, we see reductions, particularly for Pfizer, in the under 70s, and for both vaccines in the over 70s. The events have also been associated with thrombocytopenia. Again, it's rare. There were only 1,167 events in vaccinated and unvaccinated individuals during follow-up, and we see hazard ratios of about 2 for Oxford AstraZeneca, but not for Pfizer. No suggestion of increases in the older individuals. And finally, we chose to look at lower limb fracture as an outcome that shouldn't be associated with vaccination. And in the under 70s, we see no association. In the over 70s, we see lower rates of lower limb fracture, suggesting that in the over 70s in particular, healthier individuals may be being vaccinated, and there may be residual confounding of the associations we're reporting. These analyses are being conducted as a part of a large set of analyses being done through the Longitudinal Health and Wellbeing National Course Study, one of a number of national course studies established by Sir Patrick Vallance in the autumn of 2020. And we're investigating all of the themes listed here. So reflections on all this. This has really taken unprecedented collaborations across multiple institutions, accessing unprecedentedly large and detailed data sets. It's clear, I hope it's obvious how important these results can be for public health during the pandemic. It's also essential to retain public understanding of and consent for the use of these data for research in the public interest, and both during and I hope after the pandemic. And that's a live issue that has to be taken extremely seriously. A collaborative team science approach is crucial. Trusted research environments, at least in England, were developed as part of the pandemic response. They actually existed already in Scotland and Wales. Substantial computational resources are required, and these may not be scalable as the number of users increases. And indeed, we've been running into problems in trying to do these analyses rapidly. It's vital that people using these resources explain clearly how patient confidentiality is protected through disclosure controls. And for fair use, particularly interoperable and reusable use, we really need to integrate open science approaches in all aspects of this TRE. And Ben will say more about how those approaches have been adopted in Open Safely. Thank you very much.
Brilliant. Thank you very much, Jonathan. As you say, there's a couple of points, particularly some of those you brought up on the last slide, that I think we'll pick up on the discussion. So now we move on to Rich Fry, who's going to talk about the SAIL database. And over to you, Rich.
Thanks, Neil. Just waiting for the slides to be shared by the technical.
Alex, can you show Rich's slides, please? Thanks. There you go. Thank you.
Thank you. Just a quick note. My colleague Laura North was going to be presenting this, but she's not feeling very well today, so I'm taking over and I'm hopefully doing a good job. But also to Joe Hollinghurst, who's done a lot of the work involved in this presentation. It's on behalf of a wider team, as always with these things. These are the predominant colleagues who've been working on the data side, but a big shout out as well to the technical support team and the guys who made this all possible within the Cell Data Bank in Wales. So for those of you who don't know, the Cell Data Bank is an anonymised data bank, a trusted research environment within Wales. It houses all of the sort of primary care, secondary care data for the population of Wales. But we also have some other non-health related data, administrative data, which we supplement with some geospatial data, which is where my speciality lies. As a result of COVID, we've rapidly onboarded a load of COVID-specific data sets from our colleagues in the NHS Wales. And what's really changed as part of that is the kind of the update frequency around these data. Typically, before the pandemic hit, we would be taking monthly or quarterly updates of data from the NHS, and this rapidly changed to a daily update given the severity of the disease. And that's really taking a massive technical challenge and infrastructure change for the Cell Data Bank. The Cell Data Bank has been made available as a resource to the Technical Advice Cell, which is the Welsh equivalent of SAGE. And we also feed into SAGE directly through various representation on panels. I sit on the SAGE Social Care Working Group. We've got other colleagues who sit on the SPI-B and SPI-M. So that's really to bring a Welsh input into the kind of wider UK scene. And I also want to shout out to the Cell Consumer Panel, who've changed their way to work, as we all have, but really made themselves available to help us get the PPI input into a lot of the research we've been conducting over the past 18 months. Next slide, please. So as I said, it's a big team. This has been supported by an MRC grant in particular, but as a One Wales approach, so we've taken our existing links with Welsh Government and NHS in Wales, Public Health Wales, and really brought together a collaboration. We've also expanded that collaboration beyond Wales to include colleagues across the UK and getting real expertise to input into what's going on in Wales in particular. My colleague Jane Lyons in particular has developed these 2 cohorts to help us understand what's been going on in Wales. It's based on a multi-morbidity cohort she's been working on, but this was quickly adapted to 2 cohorts known as a C20, which is a COVID-specific cohort, and a C16, which is a counterfactual cohort. This has all been published in a BMJ Open article, which is, I've got the link on here. But within that, we've been introducing some advanced spatial analytics, which is what I'm going to talk about today. And I say it's direct reporting into various government committees. Next slide, please. So one of the first data sets we onboarded in collaboration with the Zoe group in King's is the self-reported Zoe data set. I mean, many of you will have heard about the app, which is available to self-report symptoms. What we took, working with, in particular with Peter Diggle in Lancaster and Helen Stagg in Edinburgh, we developed a method to give some very early insights into what was going on within the pandemic spatially at a lower super output area, so about 1,500 people on average across the UK, to really fine-grained resolution data analytics. And this was done for the whole of the UK, updated weekly, and it went into Welsh and Scottish governments in particular to supplement the data as the testing data that was being developed, and to give these insights on how the pandemic was changing and spreading, and kind of using some symptomatic approaches, which was been detailed by the Zoe team. That's all, again, it's all available in a medical informatics journal if you want to get some more details on that. But what was really important about this sort of analysis was that we show these intra authority variations, so the very localized variations within prevalence. And we're also able to provide some probability indicators around whether the prediction was a reasonable prediction on the prevalence within the communities. And this really helped inform Welsh and Scottish governments in their initial phase of the pandemic about kind of adding to that pool of information to understand what was going on within these 2 countries. This data has been made available via the Cell Data Bank. It's been freely available for people to access via the sort of standard application procedures. And I think it's about 100 different projects that end up using it for their various different things. So it's a really good example of how making the fair approach to these data sharing in conjunction with the Zoe group in King's and making it available for everyone to use as they need to. Next slide, please.
Alex, are you there? Can you just do the next slide, please?
So a few technical issues. There we are. So what we were able to do as sort of the more testing data became unavailable in a Wales-specific context is use some of the PCR testing data, which we were able to link to discrete locations in homes and LSOAs, and apply the same modelling techniques using the PCR testing data feeding into TAC. Now, that enabled us to create these high-resolution models of the COVID spread across Wales. The animation here, as it goes through, you can see just how that changes particularly over wave 2. And what we were able to do in particular was to visualise this change, and this became a really important communication tool for Welsh Government to explain to the general public why some of the decisions they made around extending lockdowns or fire breaks. It was used in the various briefings by the First Minister and Health Minister in Wales, but also it was widely reported in the media, which enabled the Welsh public to engage with how the anonymised data was being used and to see kind of some of the decision-making processes that the Welsh Government were making. It's fair to say not everyone liked it, but I think most people found it a very useful way of visualising the COVID spread across Wales. And I think that was perhaps one of our sort of things we learnt around it, is what the numbers associated with this map perhaps didn't matter so much. It was the change over time which really got people engaged with it. And these data visualization techniques, taking sort of very complex data models but communicating them simply, really helped with people's understanding. Next slide, please. Another method, so is that those are the explicit spatial data methods. We've also, with the cell data bank, we're implicit methods by linkages through geography. And that's a really important aspect of how we have used cell data. We're able to link by various geographical indicators, including household level and care home level. My colleague Joe in particular and Laura on this have been doing a lot of work over the past 18 months trying to understand the impact of COVID on care homes. And this all feeds into the social care working group at a national level. And we see there's a really sort of, there is a variation across localities, and trying to unpick that is very complex. Next slide, please. And the final bit of bringing all this data together, another one, we're using administrative data in particular and linking it through geographical linkages, is we're able to do some modelling around schools. I'm not going to steal my colleague Dan's thunder. He's talking later in the lightning talk. So please go and see that if you want to go and find out more about how we use SAIL to understand what's going on within the school environment. But I should also say we've enhanced this data with some of the qualitative data. My colleagues Sinead, Brophy, Michaela James and Emily March have been conducting some surveys within schools in Wales to get people's views and then really understand how people want to use this data and their fears around COVID. Next slide, please. It has been a team science approach, and across the whole of the HDR network. If you want to find out more about what we've been doing, there's been a great series of blog posts going out over the past 18 months on the Population Data Science website. So please engage with that. And I would really like to emphasize again that the technical infrastructure underlying SAIL is really what makes it happen. And so a big shout out to those guys who've been working so hard over the past 18 months.
Great, thank you very much, Richard. That's fantastic, and we'll pick up some questions at the end. But without further ado, we will move on to Ben, who is going to talk about Open Safely, and I'm sure we'll cover some of the aspects around potential code sharing and issues as well. So over to you, Ben.
Hey, thanks, and thanks for having us. Let me just try and find a way of, can you see my screen okay?
We can indeed. We can see your entire screen at the moment with all of your toolbars as well.
Oh, they're leaky devices, aren't they? These awful contraptions.
We can see the slide, but we can also see your.
That's better.
That's right. Fine.
Hey, well, thanks for having me. I'm here to talk today about Open Safely, which is a new full open source, highly secure analytics platform that we built during the COVID-19 pandemic. And it's now running successfully, delivering outputs across the full pseudonymized primary care records of 58 million patients in England, linked onto various other additional data sets. I'm going to talk a little bit about some of our specific research outputs, but mostly I'm going to focus on how it works, and in particular, our collaborative open working practices and how we set out to combine best practice from the research community and also the open source software development community. So first up, this is a huge collaboration across my group, the Data Lab at the University of Oxford, the Electronic Health Records Research Group at London School of Hygiene and Tropical Medicine, led by Liam Smith, but also electronic health records vendors, TPP and EMIS, who've given pro bono collaboration during the pandemic. And lastly, in close collaboration with NHS England, who act as the data controller for this national trusted research environment. Just to give you a quick overview of the kinds of data that we have, we've got every individual patient's full primary care GP record. So that's all diagnoses, tests, referrals, prescriptions, and so on. Amounts to around 100 billion rows of data in total. It's about 10 or 20 times larger than the GPES extracts. We've got that all linked onto various other sources, including SUS, which is like HES for hospital admissions, outpatients visits, ECDS, coded A&E attendances, CPNS, which is fast flowing death in hospital from COVID, SGSS COVID test results, COVID vaccination events. We've got ONS cause of death in and out of hospital. We've got a household identifier, and I'll show a little bit about how we use that later. We've got ICNARC ITU data in collaboration with the fantastic team at ICNARC, and we've also got ISRIC data and various other sources alongside all of those. And data flows with unprecedented speed for a full electronic health record. So GP data flows with a 1-day delay, vaccination with a 3-day delay, and we choose to rebuild the Open Safely mirror about once a week. So for vaccine research, the data is 4 to 11 days behind the clinical event, but could be 4 days if there was a strong operational requirement. And it's an unusual model, what we've built. To preserve patient privacy, we don't let users download data onto their own machine to work on our own data, because we think that's an insecure way of working. But we also aim to go beyond the normal standards of a trusted research environment. We don't give people remote desktop access where they're able to even view the data. Instead, we've built a full suite of open source software tools that allow people to work securely with the data, which I'll cover in a mo. So just to give you a quick flavor of outputs, this is our Nature paper from July 2020, which arose from our preprint, which we got out 7 weeks after project commencement. This is really showing the power of British electronic health record data writ large. You can see here a fully adjusted model for factors associated with death from COVID-19. And it was really the first time that we were able to account, for example, for whether the substantially higher mortality tragically amongst people from BAME communities was attributable to the higher prevalence of pre-existing clinical conditions such as obesity, hypertension, diabetes. And you can see in the fully adjusted model compared with the only demographically adjusted model that the excess mortality persists. Next is this paper in the BMJ where we looked at whether living with primary school and secondary school aged children increased or decreased your risk of various COVID outcomes. That's important, firstly, of course, as a policy question, but also it demonstrates the power of being able to link data about individuals within households in order to understand the relationship between cohabiting with different people. This is our Lancet paper from earlier this year, where we look at factors associated with various different COVID outcomes broken down by ethnicity with a really detailed, fine-grained analysis. And in particular, it speaks to the power of fast-flowing data, because we were able to show very striking differences in the marginal additional risks associated with different ethnicities between wave 1 and wave 2. And then looking at the power of, again, fast-flowing data, these are our vaccine coverage reports. So on the left, you can see top left is the MedArchive paper describing how we track vaccine coverage in 57.9 million patients, primary care record. But top right, you can see our weekly report. So because we build our code base as reproducible analytic pathways, that means we're able to re-execute our code on regular cycles. So we've been sharing these dashboards since the beginning of the vaccination program, first of all to Valence Whitty and various senior leaders in the NHS, and then publishing them a couple of months after that. And we also share the CSV files, so we find that FT and BBC and others take them and make more attractive graphs than we've made here. But you can see here very striking differences in vaccine coverage by ethnicity, which others were able to see, but also very striking divergence in vaccination coverage between people who do and do not have a learning disability, which then reconverges towards the end of May. And that really, again, is only possible by running code across the full electronic health records of 58 million people. And then lastly, this is our paper looking at use of the formal SNOMED codes for diagnosis of long COVID in primary care, in which we showed very early on that there was a concerning underuse of these codes. That paper, I think, will be out in British Journal of General Practice shortly. So our objectives in building the Open Safety platform were better privacy engineering to justify the huge volumes of data that are necessary in a pandemic. So no downloads of data, but also no viewing of data. But we also wanted to impose modern, open, collaborative computational data science working methods. We wanted to be transparent about all actions on the data in order to earn public trust. We wanted modular and portable code, and we wanted a low startup costs because this is a low or no resource setting, and we were unable to find any prior existing open code that could be reused. And lastly, we thought it was important to share all methods, but of course, share no personal data. So let me just walk through a couple of our design principles. Number one, we took the analytics to the data. So we built the platform in the data centers where the data already resides. That means the TPP and EMIS data centers where people's primary care records are already cited. Now that's important for a number of reasons. Firstly, it's a good place to build a trusted research environment, although there are other places, of course, which are secure data centers in which to build. Secondly, it gets very fast data flows because 100 billion rows of data is a lot of information to work with and slow to move and to extract. But lastly, and really importantly, it brings close collaboration with electronic health records vendors. And they build the systems in which clinicians and administrative staff record this data, and they have a huge amount of knowledge and expertise. So our work with TPP and EMIS has been absolutely fantastic and something that we're looking forward to expanding over the course of the coming years. Secondly, we made design choices about how the platform works, and I think this is really, really important. We made one single choice from which everything else follows. OpenSafely is a range of flexible, pragmatic, but broadly standardized tools that users work with to convert raw data into research-ready data sets and then execute code across those data sets. And standardizing the data management pathway in that way brings lots of benefits around reusability, efficiency, security, and transparency. First of all, it means that all code for data management and analysis can be shared informatively for review and reuse by all subsequent users. Classically, when people work to convert this kind of raw data, which is then pseudonymized into a research-ready data set that looks like this, they use a huge range of bespoke duplicative methods in a range of different tools, a bit of SQL, a bit of Python, a bit of R, a bit of Stata. In OpenSafely, the data management is always done the same way, using the same OpenSafely tools. So code is created in a form where it can be quickly read, understood, adapted, and then reused by any user for any other data science project. And that's the key to our productivity, getting papers out so quickly and now shipping outputs at a rate of maybe 1 a fortnight, including with a range now of new external collaborators who are being onboarded into the platform and can reuse all the existing code. Secondly, by standardizing the data management, we can achieve better privacy for patients through dummy data. So users are blocked from directly viewing the raw patient data or even the research-ready data sets, but they still write code as if they were in a live data environment. And that's because the data management tools used to produce their research-ready data sets also produce simulated, randomly generated dummy data. So you can see here, highlighted in pink, an example of the part in the command where you say, I'm expecting the prevalence of COPD to be 5% in the population. We then give researchers that dummy data and they can use that. We provide a full offline development environment where they can build all their data management and analysis code quickly, but only against dummy patient data. So that minimizes all needless interaction with disclosive pseudonymized patient records, and it allows anyone with technical skills to swiftly check and reproduce the methods. And only when their data management and analysis code is capable of running to completion does it get packaged up inside a container using a tool called Docker that gets sent through to execute against the real data in a live data environment, which the researcher never needs to enter. So that's really important. Now, from that follows our final move, which is transparency. It's really important that we are transparent and accountable to the public about how we use data. Normally, TREs try and keep logs of people's activity against real patient data by keeping a video of the screen or by keeping key logs of every keystroke, which is a bit like trying to reconstruct the ballet from the footprints on the stage afterwards. They can't share the code for data management and analysis because that code, because it was generated in interaction with real data, has a very substantial risk of disclosing private information about individuals. In OpenSafely, because all code is developed against dummy data, that means that we can share all of our code openly, and so we do. If you go to jobs.opensafely.org, you can see a live log of every single analysis that is currently executing against 58 million patients for electronic health records data. You can click through, get more information about each project, and if the project is completed, all of the GitHub repo will be open, and in many cases, researchers choose to share it beforehand. So then you can see the full code of everything that was executing live as it goes. Lastly, just to talk about pooling best practice, we set out, as I said, to combine best practice from academia and the software development communities. So that means open code, but it also means a number of other behaviors. First of all, we aim to have open documentation for everything as we go. So if you go here, you can see all of our code, but you can also see the full user manual for anybody who wants to use OpenSafely. And if anybody listening to this wants to work with OpenSafely, you can go to docs.opensafely.org, read the manual, download the tools, or use our interactive online web development environment, which is a bit like Google Docs, but for OpenSafely code. And then in there, you can start running your own code and developing your own code against dummy data without any permission. We also have walkthroughs where you can see a live example. Here's one of how somebody can use the platform to write code using R. You can see all of the code online for research, review, evaluation, security evaluation, and so on. You can use our interactive tools and so on. And lastly, just to say, people come to events like this because they work in the field, so get involved. 5 things. Number 1, come and do your research in OpenSafely. Number 2, come and join our team. Just email us your CV. We're keen to talk to anyone who's got strong data science skills in this space. Number 3, you can develop platform code as part of our actions library. Number 4, we need funding to sustain and accelerate to get more people access. And number 5, if you've got a data center containing data, we're already building OpenSafely in, it's working in TPP and EMIS, which is where we have 58 million records with federated analytics running successfully across the 2. We're also building it in a number of other data centers, including across an integrated care systems near real-time data in Liverpool, and we're happy to build. And the advantage to you is you get a huge existing code base and an existing community of strong analysts to work with. Thank you.
Brilliant, Ben. Thank you very much. So we're going to have a few bit of questions and discussion, but I guess one of the things that has come up from this, from several of the talks, but particularly yours, Ben, is that FAIR wasn't really, it was designed in, if you like, in the old-fashioned way, where you take a data set and you'd move it and you'd say, can we know who's got this data? But actually that's becoming less and less relevant. So I guess one of the questions to everyone is, you know, is there any value now in pursuing FAIR in the way that we originally had, if moving the data is not really the way that you're going to be working anyway? And the other question maybe to everyone as well is, FAIR, it was intended for one purpose, but it doesn't tell you, you could have a data set that's beautifully fair, but actually is rubbish, has no provenance, etc. So how can we and how should we be sort of working with particularly patients and the public around, should we still be emphasizing FAIR, or should we actually be talking more around the best use of their data and all of the other elements. And I know that you've all touched on these to some extent, but maybe just as it's sort of most directly linked, maybe I could start with you, Ben, and then pass on to Jonathan and Richard, just for your general views.
Look, I think it's the core question of our age for data science. It cuts to the core of public trust and accountability, but also efficiency. I'm very concerned that the health data research community in the UK has fallen behind other areas of science. In structural biology, in structural genomics, in physics, it is normal. It is universal common practice to share all of your code for every bit of work that you do, and to have huge, massively collaborative papers where there are hundreds of people named as the developers, the engineers, and the domain experts, the researchers who contributed to the paper. I think what we've seen in medicine is partly we've been a victim of our own early successes. And as a consequence of that, we've got a lot of legacy ways of working. We've fallen into bad habits. Trusted research environments are the answer to this, without question. And I think with the controversy around the GP data extract, where a lot of campaigners and professional groups have got anxiety about the data being disseminated, trusted research environments are a really important part of winning hearts and minds in that battle, because firstly, it's how we show that we're not disseminating pseudonymized but re-identifiable data in a way that risks patient privacy. But also, good, solid, trusted research environments can be the core of building a modern, open, collaborative, computational data science ecosystem. If all researchers are coming to the data, working in the same environment or the same kinds of environment, in settings where they are not just facilitated, but also obliged by automatic action of the platform to share all of their code for review and efficient reuse by other people working on the same data, then we get a huge uptick in productivity and in quality. So I'm really concerned by some of the trusted research environments that I see developing, because what I see is the re-emergence of some of the old monopolies. And I'm particularly concerned by some of the language that's being used around open working, where it's something that's very easy to talk about, but I think there's a really big difference between sharing a little bit of code, sometimes as the appendix attached to a paper at the end, versus sharing all of your code routinely from the moment you begin in a modern, open, collaborative data science ecosystem. And what we've seen in Open Safely is a huge number of people, especially younger researchers, who want to come and work in the latter way. And I think we're in a transition period, and it's really a question of how quickly we embrace it. But it is the key to public trust, and it's the key to efficiency, sharing code automatically by default and moving away from these closed platforms, which are closed by design.
Okay, excellent. So Rich, maybe over to you just for your views, and then come to you, Jonathan.
Yeah, I mean, so from the Sale Data Bank view, we've always had this public engagement as part of our FAIR approach through the Information Governance Review panel. And I think that's key to it, getting this understanding, this public involvement in how research is conducted, and all the things that Ben said about code resharing and making it available for transparency, but also involving the public all the way through the research process. I think that's become more and more important now, and people want to know what's happening with their data.
And Jonathan, do you want to make a comment then around how the sort of NHS digital TRE is working in this regard?
Yeah, maybe two comments. Firstly, to say that researchers need to be talking directly with patients and the public, and need to be putting effort into that. So we start by running training workshops where we explain the underlying, the nature of patient data and digital health and health services data and uses for artificial intelligence. And having done that, we then run workshops in which we present particular plans or results and get feedback. And that needs to be incorporated in all aspects of what we do. But to relate it back to Ben's comments and to these concepts of findable, accessible, interoperable, and reusable, I think the concepts have, as you say, Neil, got behind. For example, in the NHS Digital Trusted Research environment, we have controls on what you can export, and it's appropriate that there are controls on what you can export. But the nature of the controls on what you can export inhibit directly sharing the code that we are running and what we're doing in real time. And the elegance of Open Safely is that they anticipated that problem at the beginning and designed solutions to that problem at the beginning. So it's very much a work in progress. And again, to echo what Ben said, we've got to be completely frank that about the nature of the research that is being done, and have really frank conversations that acknowledge people's concerns and acknowledge the need to protect people from having their data used in ways that are unacceptable to them, and acknowledge our willingness to adapt the ways that we work. From the commentary that I've seen and heard, people are signed up to the vital importance of these analyses and the way that they have saved lives at scale. The fact that these analyses on detailed linked data were done, they have concerns, and we have to face up to those and address them, and not simply mouth platitudes about you can trust us. We've got to demonstrate trustworthiness and build trustworthiness into the way we work.
Okay, brilliant. Now, I know we're slightly late for time, but I'm going to ask one other question. I realize that some people may need to drop off before the next session, but we've got a few minutes before the next session starts. So firstly, those of you who have put questions in, there's some specific questions for the speakers that are very specific, which we will pass on afterwards separately. But just as a general thing, I'd be interested in the panel's view on something that, in fact, Ben and I have talked about, and I kind of feel quite strongly with, and you touched on, which is that of authorship. There's a whole load of work. You mentioned this also as well, Rich, with, if you like, what are still considered the back end team, the people that deal with the ETL, the data engineers, the people that build the platform. And traditionally, it's been quite hard for those people to have a career structure and to get authorship on papers if you're not one of the sort of core academic team. And I just wondered what the views of the panel were just in the last couple of minutes on that. So maybe start with you again, Ben, and we'll go on.
So we put developers absolutely at the core of our team. It would be inconceivable not to. We also pay our developers well. There's a culture, I think, in academia and the NHS of expecting that software developers are somehow in the same category as people who do technical support to repair your printer. The reality is that computational data scientists and software developers earn 120, 160,000 a year routinely, and they'll take a substantial pay cut to work for public good, but not down to 40. I think it's reasonable to pay people with those sorts of skills professional salaries in the same way that we do clinical staff when they transition into academic roles. I think you're absolutely right to touch on incentives. I think that's at the absolute core of this. I think we need to repair it ourselves by making sure that we foreground developers, but I think we also need funders to step up and recognize that all quantitative research is done by writing analysis scripts, and analysis scripts are software, and software is eating research. If we're going to have good quality research, then we need our researchers to have good basic software carpentry skills. We need them to work in collaboration with people who have good software skills. And that means that we need to fund them. It means that we need to fund fellowships for research software engineers, which again are very strong in other settings, but there's been a strategic failure, I think, around health data research in the UK, where we haven't invested in software developers as a core part of the team. Bespoke fellowships, bespoke career paths, high status activity, but also funding open code. I think there's been a traditional approach of viewing TREs as being somehow a commercial product to be externally procured. And I think that has its role for generic data science environments like Databricks. But you need bespoke code that's specific to the needs of electronic health records researchers to bridge the gap between academic researchers, service analysts on the one hand, and a raw, naked computational environment like Databricks. And that is code and working practices that come about from software developers working hand in hand with researchers.
Okay, very good. Just quickly then, maybe 1 minute each to finish off. So Rich, over to you, and then Jonathan.
Yeah, I completely agree with Ben. I know our experience in Swansea is it is hard to recruit at the right level. for some of these roles because of the skills and the university structures that sit around pay for these types of roles do not match what the industry is paying, and you need really good people to create good science to support it. And also it extends also to the teams which manage the data acquisition and all those kinds of roles, these hard negotiations with data providers. It's all a part of the sort of platform which then you can do the great science on, and I think that needs to be recognised further.
Jonathan, you get the last word.
So just on authorship, I think we've all emphasised the team science nature of what we're doing and the fact that large numbers of people contribute to what in the end becomes a research paper published in a conventional research journal. We're halfway through the battle in the sense that journals allow us to publish papers with very long lists of authors, as they should, because very large numbers of people contributed to the research. But we have to do some double think in that the specific criteria for authorship that are used in, for example, the Research Excellence Framework, and more specifically are used by the journals to say, I have to tick boxes to say I did this, simply don't apply in this era. And as rapidly as possible, we need to realign the definition of authorship to this era of team science.
Okay, brilliant. Well, we're going to have to finish there. This particular discussion, I could go on for a long time, but let's finish there. Thank you very much for all of the speakers. Brilliant stuff. You all have now 2 or 3 minutes for whatever you need to do in the next 2 or 3 minutes before the next session starts. So thank you again to everyone who's attended, and big thanks to all of the speakers. So thank you to Jonathan, Ben and Rich. Thank you very much.
Cheers all.